Hello, my name is Vladyslav Dieiev. I'm a medical intensivist in Wisconsin, United States, and today we will be talking about shock. More specifically, about how four hemodynamic interface concept can help you diagnose and treat common disorders of circulation in your shock patients in the ICU. Let's start from reminding ourselves what shock actually is. Shock can be described as a mismatch in oxygen delivery and demand due to reduction in tissue perfusion that results in end organ damage and clinically presents as vital organ dysfunction. So common formula that has been used to describe oxygen delivery is by multiplying flow, like in this waterfall, times the oxygen content in the blood that will be represented by hemoglobin and the oxygen saturation of that hemoglobin. So the flow is really what we will be talking about today. One useful concept that or analogy that can be used to when we talk about flow is by thinking of the flow problems as a problem of the train. When the train has an engine, which would be our cardiac output, and it has cars, which would be our hemoglobin, loaded with a coal, which would represent oxygen, and circulatory shock is fundamentally would be a problem of the train engine and perhaps the railroad that it's traveling. So under this concept, it's widely believed that by increasing the flow, like in this case, making 3 waterfalls out of 1, can increase oxygen delivery to the vital tissues and help improve perfusion to our patients. Another way to describe the flow or cardiac output would be to put the difference in between highest pressure point in the circulatory system or map and subtract central venous pressure or right atrial pressure, which would represent the lowest pressure point in the circulatory system, and divide that by systemic vascular resistance. And the parameter that we as clinicians frequently use at the bedside to understand the perfusion status of our patients is usually blood pressure. And blood pressure, or in this case, MAP, mean arterial blood pressure, could be described as the product of cardiac output and systemic vascular resistance, and CVP would be added to that. Because CVP on the normal condition is 0 to 3, frequently it's omitted from this formula. Well, the problem with this approach is that even though it gives us mean arterial pressure, or it gives us the final number, what it does not tell us that how much of the blood pressure is due to high cardiac output or low cardiac output, how much of that blood pressure is due to SVR problem, and how much of that blood pressure is due to CVP. And it's up to us as clinicians to understand how those individual components are contributing to blood pressure in every individual patient. Because sometimes we can run into a problem similar to this bicyclist who is trying to ride the uphill. So he's trying to, in other words, achieve the advancement or flow, but yet his wheels are not really spinning in an effective manner, meaning that he does not really advance. And that brings us to those 3 clinical scenarios that I want you to describe here to illustrate what I mean. Mean arterial pressure could be 65, but if we have a low forward flow, then clues to that would be narrow pulse pressure or cool periphery. There will be reduction in LV stroke volume, and the patient may not have a good perfusion. So clinically, they would look cold, and they might have lactic acid elevation in the blood. Or the other scenario where blood pressure can be normal, like 65, the patient may be warm and the heart may be pumping really well, but yet SVR could be extremely low. So we will still see that patient is mottled, that the microcirculatory perfusion is just not happening. And the third scenario, where MAP also could be 65, and the patient could be 10 liters of fluid positive balance and have B lines in the lungs, or wet X-ray, could have congestion and very, very high CDP. CDP could be in 20s. So the perfusion pressure could be very low. And again, the patient vital organs will not be adequately perfused at that time, even though mean arterial pressure remains normal. So one way to describe this physiology is to conceptualize circulatory system as an interaction of four interfaces. First interface is LV to systemic arterial, and it describes how left ventricle is able to interact with aorta during systole. And it answers the question, is there enough forward flow for this afterload? The second hemodynamic interface describes microcirculatory perfusion and its arterial to capillary interface that answers the questions, has the pressure that we have seen at the macrocirculatory level transferred into microcirculatory perfusion? Interface 3 describes venous return, or interaction between capillary into the venous side, more specifically about how mean systemic filling pressure gradient to right atrial pressure can help drain venous blood from vital organs back into the heart. And finally, interface number 4 describes interaction of the right ventricle with pulmonary artery. And it answers the questions, can the right ventricle still eject the blood into the pulmonary artery under given RV contractility and pulmonary vascular resistance? So here we can see that shock is really sometimes could be described as an uncoupling of the specific interface or a few of them, and not as a problem of the flow, just the flow in the entire circuit. How do we measure those interfaces? How do we conceptualize which interface has been broken in every individual patient? Here are some clues. For interface number 1, we will typically use pulse pressure, or the difference between systolic and diastolic pressure, and LVEF. There are some more advanced measurements that we can do that will give us a better idea of stroke volume at any given time, and how that stroke volume being ejected throughout the systole. Some of the more complicated measurements can involve understanding of relationship of isovolemic contraction of the left ventricle relative to ejection phase. Interface number 2 at the bedside mainly can be understood by measuring capillary refill time, Motlin score, diastolic blood pressure, as well as by some other more advanced modalities. Interface 3 is usually assessed by presence of jugular vein pressure, jugular venous distension, and increase in central venous pressure. Edema is one of the useful clinical markers of overall body fluid overload. And one advanced modalities that we use at the bedside is venous excess ultrasound, or VEXUS, as well as some other Doppler modalities. And for interface number 4, assessment mainly captures the assessment of the right ventricle at a basic level. Again, it includes assessment of the jugular venous pressure, CDP, and specifically CDP waveforms to understand how the right ventricle is able to move the blood forward into the pulmonic vasculature. At advanced level, most of the measurements involve some type of assessment of RV contractility and how that contractility interacts with the elasticity of the pulmonary circuit. So more specifically, talking about interface 1, this is what essentially we are assessing. If we look at the pressure volume loops that describe LV contractility, here's the contractility starts, LV volume is high, pressure is low. We see the isovolemic contraction as the first step, then ejection phase, isovolemic relaxation, and finally passive filling of the left ventricle. So those phases will change, depends on the change in the contractility and depends on the elasticity of systemic vascular circuit. So, for example, if the elasticity of the aorta changes or elastic load on the left ventricle increases, it can interfere with ejecting the blood. At the same time, if your contractility of the left ventricle goes down, it will result in diminishing returns of the stroke volumes. So clinically, it would look like this. Patient would have low LV systolic function on the bedside echo. They would typically have very low forward flows as measured by LV-VTIs right here. And the IVC would look pretty plethoric. Interface number 2, your circulatory, your microcirculation will largely be reflected by skin exam at the bedside. So Motlin score has been associated with certain levels of mortality. For example, in this paper, the Motlin score of 5, which means the Motlin extends all the way down to the groin, actually has been associated with more than 90% mortality, while Motlin around the kneecap only is associated with much lower mortality of about 10%. So that's how uncoupling of interface number 2 would look like. You have delayed capillary fill, you have mottling, your LV may be actually doing pretty well on the point of care ultrasound exam. Interface number 3, uncoupling, is usually missed. And the reason it's missed because really there is nothing in this oxygen delivery formula that describes venous return. And that venous congestion really affects organ perfusion in a major way, especially encapsulated organs like liver and the kidney. So it's important to keep that in mind, and especially a lot of us practice resuscitation by the Rivers trial or a lot of other literature that describes that maybe you should be infusing the fluid up until your CVP rises above 8. So if CVP less than 8, some protocols could mention administration of crystalloid or colloid to achieve target mean arterial pressure of 65. Well, the problem with that is that CVP really has a very low correlation with volume status, like was nicely shown in this paper. As you could see, you have any range of CVP and any range of volume status, and there is no correlation of those parameters whatsoever. And the other paper that assessed septic patients in the ICU who were mechanically ventilated, there was CVP correlation with volume responsiveness was very low as well. So actually positive predictive value was 50%, meaning that whether a patient will actually respond to fluid bolus with CVP less than 8 was CVP was as predictive as flip of a coin. And in this animal experiment on interaction of CVP or right atrial pressure, volume, and IVC, I think was nicely shown that CVP actually rises steadily with the volume, but IVC perhaps is more sensitive. IVC dilation specifically is probably a little bit more sensitive than the CVP to changes in volume status. So how does the disorder of interface number 3 looks like? Well, frequently we measure it by performing venous excess scan. And here we can tell that there is a systolic S-wave reversal, and you can see the same exact waveform if you just transduce your CVP tracing on the monitor. The portal vein normally should have a continuous flow, but here we can see it's substantial amount of pulsatility of the portal vein flows, and the renal vein actually only has flow during small periods of time. Right here, the renal vein flow are below the yellow baseline on this Doppler image, and instead of being continuous venous flow, we can only see those D waves present, so which indicates severe venous congestion in the kidney. Interface number 4 describes interaction between right ventricle and pulmonary artery. In typical classic disorder for interface number 4 will be something like pulmonary embolism, where we see A lines, we see significant RV dysfunction and plethoric IVC. Here you could see that RV appears very big on this point of care ultrasound. This is the continuous wave Doppler over tricuspid valve, shows significant tricuspid regurgitation, and here we are measuring RVOT VTIs from subcostal approach, where we look at acceleration time of right ventricular LVOT VTI waveform that can indicate high right-sided afterload. So again, disorder of right-sided of interface number 4, right heart, can lead to substantial perfusion problems. And if we go back to the pressure volume loops, that interaction that we discussed during for the left ventricle, how the left ventricle interacts with aorta, similarly right ventricle, when it interacts with the pulmonic vasculature, if the afterload of the right ventricle becomes excessive, it leads to what we call uncoupling of interface number 4, and leads to reduction in the stroke volume and can lead to substantial perfusion problems. One of the other clues that we use clinically to differentiate different problems of that can lead to interface 4 uncoupling is by examining the shape of the waveform of RVOT VTI, where if we look for early systolic notching, if that notching is present in during the systole, that would be highly indicative of having acute pulmonary pressure elevation that we see in pulmonary embolism patients. Those are some other parameters, just at a larger scale, that can be used to assess RV dysfunction. So, for example, tricuspid regurgitation can be measured, and usually during acute RV afterload elevation, that measured RVSP would be less than 60, would be indicative of, again, pulmonary embolism or other etiologies of acute pulmonary hypertension. Whereas RVS prime is a surrogate for RV systolic function, and it can be measured by putting tissue Doppler on the tricuspid annulus, and it can assess RV longitudinal function. So let's look how those concepts can play out in real life. Here's the case. The patient, 67-year-old, history of COPD, diastolic heart failure, CKD3, who comes in with altered mental status, feeling cold, has really limited mobility recently. His blood pressure was low, heart rate normal, and he was saturating 95% on 12 liters of oxygen, so it was pretty hypoxic. He had many signs of end organ dysfunction and malperfusion, like elevation of liver function, kidney function tests, and lactic acid. So here's this point of care ultrasound done in the ICU. You could tell that the left ventricular contractility has been diminished, as well as RV contractility. When we look at that interface number 2, you could see that patient has a mottling around the kneecap and maybe extending a little bit beyond his kneecap. When we look at interface number 3, we saw that he actually has relatively normal looking hepatic vein tracing, mostly forward flows. His portal vein here had pulsatility that was less than 30%, and the kidneys had S and D waves, so overall findings concerning for mild congestion. And while looking at interface number 4, Again, we see that right ventricular function is severely diminished. He has early systolic notch in here on the waveform, and his right-sided pressures are significantly elevated. His RVSP based on this echo was 70 plus 15, so total 85. So pretty high right-sided pressures. So putting all that together, we thought that the most important dysfunction in this patient was actually interface number 4, his RV to pulmonic vasculature, and indeed his CAT scan revealed massive pulmonary embolism. So we started nitric oxide at 40 parts per million, also administered nebulized milrinone 5 milligrams. The Butamine was started for RV support. Vasopressin was used for its preferential systemic vasoconstriction and not really affecting pulmonary vasculature in major way. Norepinephrine was titrated to the target goal of MAP more than 60. So again, we chose a little bit lower MAP goal for this patient to allow for to avoid any significant elevation of pulmonary vasculature pressures. He was started on high flow oxygen to reduce his need for invasive mechanical ventilation that could have been very harmful to the patient with significantly elevated right-sided pressures due to the effect of positive pressure ventilation on the right side. And he actually underwent mechanical thrombectomy within 24 hours. So we went from this situation all the way to this. And the next day, perfusion improved, and the patient was discharged a week later. So take-home points. Start with mean arterial pressure, but don't stop at mean arterial pressure. If the MAP of your patient is normal, but you see signs of end organ dysfunction, like a liver failure, patient is not urinating, they're not maintaining well, the lactic acid remains elevated, think of those interfaces and think which one is uncoupled. Use the clinical exam or point-of-care ultrasound to separate low flow state, poor tissue perfusion, congestion, or RV pulmonic uncoupling. And after every intervention, ask again which interface is still being uncoupled and think how to adjust your interventions to improve your patient perfusion. Thank you for your attention.